So I think so far we've had a really nice global discussion about where we've come from. And to me, I think the historical perspective of what we've done in the past, you really can't appreciate sort of where you need to go. And I think as we evolved, again, I think it's important, John, as you and I have always talked about, is standardization. Everybody again, practicing evidence-based medicine, and hopefully our outcomes and our metrics will be improved, because again, we know that as we talk about metrics, depending upon who you're talking to, the metrics change, right? If you're talking to an insurance company, it's how much money they're putting out. If you're talking to a surgical oncologist looking at the cancer standpoint, you're looking at surgical margins, disease-free. When you're talking to patients, it's, hey, did I get back to work earlier? What was my quality of life? And so I think, again, I think it's important to incorporate that into all the programs that we do, financial, outcomes, based upon length of stay, based upon surgical margins, those types of things. But clearly, what we don't do a good enough job, and you had mentioned that, is this sort of the quality of life issues. But we know that clearly one of the biggest complications that we see before ERAS and especially with GI surgery is postoperative ileus. So, Traci, give us a little bit about your impression of postoperative ileus. We know it's a huge financial burden. I think the last data that I saw is over $1 billion is spent annually managing postoperative ileus due to lengthening of stay and readmission rates. So, kind of give us your overview of how you look at it, the characterization, and I think we also want to talk about a little bit of the pathophysiology of postoperative ileus.
Sure. So ileus as a word actually goes back to antiquity, and it was originally used to describe what we now know as the modern day volvulus. But in the 19th century, it really started to be associated with what is termed a functional obstruction. So there's no mechanical kink to the bowel, but it just is not functioning properly. And it used to be felt that was an absolute unavoidable consequence of surgery and was related mainly to the trauma of manipulation of the bowel. And what we now know is that while that is important, there are certainly many other factors that go into it, namely the administration of opioids. And so if you look at the literature, it can be a bit confusing because there are several different terms. There's postoperative ileus, pathologic ileus, prolonged ileus, and it can be defined differently, and so the incidence will vary throughout the literature. There are those patients that get a little queasy on the first or second postoperative day. They may get a little burpy, they may get bloated, but it quickly goes away. What most of us think of as an ileus is those patients that develop complete intolerance of GI function. They get very bloated, oftentimes require an NG tube, and that incidence is anywhere on average 15 to 20% of patients. And while enhanced recovery certainly has reduced that, it's important to know it hasn't completely eliminated it. So it's something that we all still need to be very familiar with, knowing how to treat and prevent.
And the thing about it is that you see it across every surgical subspecialty, right? And as you said, John, even
if we're not in the belly, we see it.
Right.
Yeah,
Exactly.
Spine surgery particularly.
Right, exactly.
Yeah.
So when we look at postoperative ileus, so again, I think you've mentioned that's clearly one of the factors, one of the major factors contributing is obviously opioids. Declan, you had mentioned earlier in one of the prior segments about some of the localized inflammatory effects that go along, and you kind of casually dropped this whole concept of carbohydrate loading.
Oh,
so
yes.
Tell us a little bit about, how that plays a role, the carbohydrate loading.
There are two components to that. There's a sort of fed versus fasted state component, so it's a metabolic component, and then there's also a dehydration component. When we give a bowel prep of some sort, and on whatever side of that you stand with your various operations, most people will come in not having had the absolute normal amount of eating and drinking up to the time of the surgery. And so this carbohydrate load is a volume of fluid with preferably a complex, not a simple carbohydrate, given to mitigate that dehydration and that low carbohydrate level in the bloodstream that alters body physiology and allows people to better tolerate the surgery, to diminish some of the metabolic response to surgery, and also to put a person at a more right fluid balance during the operation, which helps to hopefully diminish the need of IV fluid. John, you'll be able to speak to this better than I could, but we've always said that 2/3 or 3/4 of the amount of IV fluid that's administered intraoperatively is not going to stay in the intravascular space. And if that's going out into something, part of what that's going out into is the gut. And that's going to cause gut edema. And I think that is also, in addition to local neurotransmitters and neural stimulation and the stimulation of the opioid receptors on the gut, I think edema plays a really significant role in the development of postoperative ileus.